Thank you for being here on this bright and sunny Friday morning. Welcome to our discussion entitled Best Practices for Ensuring High Quality Care for Incarcerated Patients, Patients' Rights and Our Responsibilities. This talk was co-sponsored by the SAEM Equity and Inclusion Committee as well as the Ethics Committee. And we're really excited to bring this fantastic panel with diverse experiences and unique practice locations to you. I can tell you this is an area that I find particularly nuanced and complex, and so I am absolutely excited to learn from each and every person who's up here, and I hope you're excited for today as well. This is our list of contributors. I'm going to ask each panelist to just introduce themselves as we go along for time's sake. Since I'm speaking, I'm Logan Weygandt. I'm at Johns Hopkins. I serve on both the Court and SAEM Equity and Inclusion Committees, and I'll be serving alongside my colleague, Dr. Kamna Balhara, as one of the co-moderators or co-MCs today. Unfortunately, Nate and Jolion had conflicts, so were unable to attend, but they truly contributed meaningfully, and I want to very much thank them for their input. In terms of disclosures, none of us have any financial disclosures, and importantly, we are drawing today's discussion based on best practices from the literature, as well as our own unique experiences at our own institutions. But it's important to highlight that the healthcare for patients in the carceral system is very much complex, and we do encourage you to consult your local institutional policies, local statutes, and both state and federal law, because this is very nuanced, and where you practice the rules, regulations, and policies may be slightly different from each of our own unique institutions. In terms of learning objectives, we do have several for today, and we hope that by the end of this discussion that we'll all be able to sort of understand a bit better the barriers to care faced by patients in the carceral system, to describe incarcerated patients' rights, as well as highlight a few of those limitations related to medical decision-making and right to privacy, apply core ethical principles to cases of patients accessing the healthcare system from the carceral system, and ultimately to utilize a few best practices to provide high-quality care for these patients. We'll do an ever so brief introduction focusing on the U.S. carceral system and barriers to care faced by incarcerated patients. And then what we're really excited to do and what we're going to focus the majority of the talk on are several specific cases that we're going to ask you to contribute questions and your own thoughts. So look forward to that here in just a second. A brief overview of terminology just so we're on the same page. So I've been using the word carceral, and essentially that's a word that suggests of, relating, or suggesting jail or prison. Jails tend to be short-term facilities, generally administered by a city or county law enforcement agency, and those typically serve those who are serving less than 1 year sentences, but also importantly those who are awaiting trial, sentencing, or transfer to another facility. Prisons tend to be longer-term facilities for folks who are serving sentences longer than 1 year. The term incarcerated is, again, a non-specific term that refers to a person who's confined to a jail, prison, or other such institution. Somebody who is in custody is a person who is physically detained in or en route to a jail or a prison. And finally, inmates are those who are confined to a prison, jail, or other correctional facility. The U.S. carceral system is absolutely the largest in the world. There are now approximately 2 million people imprisoned in the United States, but there are actually over 6 million people who are in the adult correctional system. So that includes not just those who are incarcerated or imprisoned, but also those who are under surveillance, paroled, et cetera. There are myriad factors that contribute to mass incarceration in the United States. These include local, state, and federal laws, and the incentives and disincentives, both financial and otherwise, that influence elected officials and politicians and those who pull the levers of government. Further discussion of these contributors is sort of beyond the scope of this talk, But I do want to highlight that we have a unique position as frontline healthcare providers who often serve patients in the carceral system. We can be fantastically strong advocates for reform, and I hope we all can be.
Hi, everyone. I'm Kamna Balhara. I'm at Hopkins. And I want to transition now a little bit to talking about what are inmates' rights when it comes to accessing health care. And all of this comes down to the 8th Amendment to the Constitution. Essentially, the argument is that an inmate is wholly reliant on prison authorities in order to get care. And if authorities obstruct that in any way, that potentially constitutes cruel or unusual punishment. So this sort of guarantees those who are in the carceral system access to health care. So what does that actually look like? So the essential constitutional rights of prisoners to health care are the right to access care, including specialty care or hospital care, so not just the infirmaries within carceral systems, but accessing care as needed outside of that. They have the right to care that is ordered by a healthcare professional, so that cannot be impeded in any way. And finally, they have the right to a professional medical judgment that is not biased by their incarcerated status. But as we know from existing qualitative literature, emergency physicians are often underprepared to care for patients who are in the carceral system, whether that's due to a lack of knowledge or a lack of comfort or a lack of familiarity with institutional or state or federal policies. And so as Logan mentioned, the US imprisons more people than any other nation. And people who experience incarceration at any point in their lives are disproportionately in poorer health, both before, during, and after their incarceration. So this truly is a public health problem. For instance, nearly 50% of those who've gone through the carceral system have mental health illnesses. And when it comes to chronic illnesses as well as infectious diseases, those who are incarcerated have higher rates of asthma, high blood pressure, tuberculosis, HIV, the list goes on. And as we know, people of color, especially Black men, are much more likely to be incarcerated. And so you can see how all of these kind of come together and converge on contributing to health disparities, with mass incarceration sort of acting both as a lens and a cause for disparities in healthcare. So when we're talking about correctional facilities themselves, before patients get to us in the emergency department, just briefly, what do they have available to them? And I'm sorry, but the short answer is it varies. So depending on the facility that they're in, where it's located, whether it's funded by the state, whether it's a federally funded facility, the kind of care that they can receive in the infirmaries or the healthcare facilities within the jail or prison is very variable. And despite the protections of the 8th Amendment, these facilities that are within the carceral system do not get the same level of oversight, that our hospitals or clinics might. And finally, not only is there a higher burden of certain illnesses, such as mental health-related illnesses or substance use disorders, there's also largely inadequate treatment within the prison system for these issues. So as you can see, the deck is really stacked against those who are in the carceral system. So we're going to transition now to cases and some discussion from our panel. So I'd encourage everyone to just go ahead and scan the QR code that's up there. That will take you to a synopsis of each of our 3 cases. And below that is a space for questions. You're also very welcome to kind of just offer your questions out loud. We are a small group. But if you don't feel like asking your questions out loud, you can enter them anonymously here as well. So I'll just get started with case 1. So this is a 56-year-old male who has a history of hypertension and diabetes, and he's a smoker. He comes to the ED from the state prison with the chief complaint of chest pain. So you can sort of read the details of the patient's pain itself. He's got a family history of CAD in the family. His vitals are okay. His EKG is nonspecific. You've sort of ruled out other etiologies. And at the end of the day, you're saying, okay, his heart score is a 5. And the officers that are with the patient are anxious to get out of there. They want the patient to be discharged. And so in thinking about this case, the question really would be, what would you as a clinician do next? And if you have questions for our panel, please feel free to enter them in. And so I have some targeted questions for our panel and panelists. So I think our first question is, how would your decision to discharge or admit this patient vary, given the fact that the patient is incarcerated?
Good morning, everyone. My name's Katrina Gipson, and I'm at Emory in Atlanta. So I want to make sure that, of course, we all know that you guys know how to monitor, chest pain, cardiovascular disease. So some of the ways that we answer these questions, we want to make sure that they're applicable to all folks. So I think the most important thing that we should take into consideration is that incarceration is a social driver of health, just like homelessness or low health literacy. So this is definitely something that we should take into consideration. This isn't, your maybe your 45-year-old gentleman who has a primary care doctor that they can follow up with within 24 to 48 hours. So just like you would take someone's housing status or their access to a primary care physician into consideration when you're managing their clinical disease, one's carceral status is of utmost importance as well. Things that we can take into consideration, for instance, are not the officer's anxiety, which of course can be, it can be intimidating. You have these large officers oftentimes who have guns and they're breathing down your neck and trying to get you to manage the patient in a way that is convenient to them, that may not necessarily optimize their health care. So in addition to taking into consideration length of incarceration for the patient in front of us, think about what types of resources are available to the jail. Of course, they're not going to have telemetry monitoring. They're not going to, no one's going to be checking in on this patient queue 2 to 4 hours as they would in an observed unit. But often, let's be honest, a lot of times our own biases as clinicians, we are, is this person's chest pain, if it worsens and or changes, is this going to be considered malingering or a form of some sort of secondary gain? Also, the likelihood of a bounce back is high with these types of patients as well, just like anyone else who may not have the same types of access to care. So the other things that you can take into consideration, not just when it comes to high-risk chest pain, but does a condition endanger other inmates or staff? For instance, for communicable diseases, perhaps I could tell anyone in this room to go home and isolate, but as some of our jails and prisons are becoming a little bit more overcrowded, particularly over the last several years and with COVID, what types of resources does the jail have as far as allowing the patient to either, kind of isolate? Is that even an option? We saw this in nursing homes as well. We were thinking that we were taking patients' communicable diseases into consideration, but these outbreaks kept happening because from a practical standpoint, that just was not reasonable. This is for our second question. Should I just keep going?
Sure.
All right. So for the second question, should our threshold to admit, observe, or discharge be influenced by the patient's carceral status? So I think we kind of addressed that, and the answer for that is, absolutely. These are very high-risk, vulnerable populations due to their carceral status. Oftentimes, they have other designations that make them vulnerable populations, whether it's their HIV status, their health literacy, their access to health care. So that's often something that we take into consideration in addition to just some of our other clinical gestalt, such as heart score, accessibility to a stress test within a reasonable time period. And then finally, so if you decide to discharge the patient, with whom should you discuss medical information? I think that this is a very important decision. We're all very familiar with HIPAA, but even for our patients who are not in custody, HIPAA always does have, there's always caveats. But one thing that we keep in mind is that the security guard who may or may not want you to expedite this patient's disposition for their own purposes is not someone that necessarily needs to be privy to their care unless it is somehow possible that it's a danger to the security officer or whomever else may be in charge of transporting your patient. Particularly, when you're discussing things, sensitive subjects like HIV status or pregnancy status, things that could adversely affect the patient in custody, either at that moment or upon return to the jail. And these are really real concerns for our patients. However, I alluded to this before, things such as communicable diseases, COVID, TB, or sometimes in certain circumstances, HIV status. But basically, as clinicians, in order for us to justify violating HIPAA, there has to be some sort of proven necessary medical reason for doing so. For instance, actually, the week before I came down here, we had a gentleman that showed up in my zone who had swallowed a razor blade. It wasn't for the purposes of, suicide or as was noted in the chart, but he was completely honest with us. He said, I swallow this for the purposes of producing it when necessary for protection. And these are nuances that we may not think about, but these are the types of things, scenarios that present themselves for our patients who are in the carceral system that we need to take into consideration. And at that time, he cooperated with us as far as allowing us to get a chest x-ray, KUB. We didn't get any additional lab work, but he actually produced the razor for his bedside nurse and quickly swallowed it. So I spoke with our medical administrator at the time, and her advice to me was, it is our job to notify the prison that the razor is in place. After speaking to the patient, it was clear that he had capacity. He wasn't actively attempting to hurt himself. However, as clinicians, it's not our responsibility to secure the jail. So after notifying the officers who already had the patient in custody, I wrote a statement to the jail as well as to the doctor, and he was discharged with the foreign body still intact. So that just kind of speaks to the fact that regardless of one's carceral status, they do still have a certain amount of bodily autonomy, particularly when they can demonstrate that they have the same capacity that you or I may have. So in addition to just your more straightforward cardiovascular disease, heart score management, you have to take into consideration these vulnerable populations, as well as whether or not their presentation or disease status is possibly a danger to anyone who's in charge of taking care of them, but always have a lower threshold to admit these patients if it means optimizing their healthcare outcomes.
Great, thank you so much, Katrina, and thanks for sharing that case. Do any of our other panelists have anything to add?
Go ahead, go for it.
Hey everybody, Shamsher, Samra from LA, and I'll speak from some experience I had working within correctional facilities, and just to echo the importance of kind of having that lower threshold for admission. There's definitely the barriers to return to the emergency department setting, including delays in care, like custody, thinking that the individuals are malingering, as you mentioned. But then there's also a lot of barriers to the follow-up care that if we write that we want cardiology follow-up in a week. Lots of things that can happen. In theory, by the letter of the law, that should happen, but things can derail that, including lockdowns in the facility. People might have unexpected court dates. It just may not happen. There may be kind of breakdown in communication between what you relay to the custody official there, and maybe it doesn't get to the medical provider in time. So just take that into consideration if the follow-up is especially timely, and if it is, needs to happen in a few days, or it is very urgent, that might shift your bar for who gets admitted. The other thing I'll say, maybe not in this case, but for folks who are coming from jail facilities, also take into consideration that people might be released, so factor that into your conversation, especially if you know the person is coming from the community in custody or coming from a jail facility. In LA, I think something like 40% of people are released in under 2 weeks. So in addition to having the plan for if somebody's in custody, also make a plan with the patient for what they should do if they are released. Probably come up with a plan C, because we know there's disruptions in health insurance when people are incarcerated. So it may mean coming back to the emergency department if they can't get to primary care or their routine forms of follow-up. And lastly, I think it's kind of obvious, make sure you communicate the plan to the patient, both so it's the right thing to do, but also they're able to advocate for themselves and recognize any deviations from what the standard of care is.
So thank you.
Just a couple of quick follow-up comments. So I'm Sandy Werner. I'm from Metro Health in Cleveland, Ohio, and we're the essential safety net hospital there. We're also kind of unique in that we provide the prisoner care. We actually provide it. We have Metro Health doctors who are in the prison, and they are connected to us through Epic, so we have a really easy way of communicating. And as far as getting those discharge instructions to the appropriate person, the person a law enforcement officer who accompanies the prisoner, is never, they should not have access to that. And whether you have a system where you put it in an envelope so it goes back to the jail physician, or have some other system, we do it all electronically, but those folks do, unless it's a safety issue, those folks are, they're not surrogates for any kind of health care power of attorney. They should not have access to the patient's information. And the other thing regarding having, ensuring that patients get care, Amendment 8 is great, but it places the burden of proof that they're not getting adequate care on to the prisoner. So it can take, and going through the legal system, if you have cancer and you need chemotherapy and you're not getting it through the prison, then it's up to you to prove that. So just keep that in mind, because that can definitely change your decision to admit somebody and make sure they get appropriate inpatient care and get started on things, because it's really, they would have to prove that they're not getting adequate care. And especially with these for-profit prisons now, because the prisoners are not, they are basically removed from the roles of Medicaid and Medicare once they're incarcerated. They're literally cut off. So, and the prison population, like there are twice as many prisoners over age 65 today as there were 10 years ago. And the prisons do not get any funding to take care of those patients, from the federal government. And if they're a for-profit institution and they have a bottom line they have to meet, what constitutes adequate health care will go down very quickly. Sorry, it took too much time.
Great. Oh, please.
When you guys are communicating results, like a patient's workup that's incarcerated, do you typically do that in front of the officers, or do you ask them to step out, or what's your common practice with that, just in terms of HIPAA and all of that stuff? I'm curious what you think is appropriate.
We're going to touch a little bit on privacy on the next case, actually. But to answer your question, whatever you can do to keep that conversation private is really important. So it's the officer has to have line of sight and physical proximity, but they don't have to be in earshot. So if it is all possible, if the person's on a flight risk, they should be on cuffs so you can examine them and talk to them uninterrupted and have dignity for that patient. And then in addition, you can ask the officer to step out. They can be nearby, but then I would try as best as you can to kind of have that conversation as private of a way as possible. I think it's hard. Everyone's dealing with boarding and hallway patients, et cetera, but as best you can, try to keep it as private as possible for that patient.
Thank you for your question, and please chime in anytime if you do have questions. We're going to move on to case 2. So in this case, a 44-year-old male is presenting from federal prison after being assaulted by another inmate. The patient is awake and alert, but has bruising on his trunk and his extremities. He seems fairly withdrawn and is really making poor eye contact. When you ask the patient questions, he simply nods. The officer who's standing at the patient's bedside says to the patient that you better answer the doctor's questions so we can get out of here. You also notice some bruising around the hand that's restrained to the stretcher. And I just want you to think about sort of what the next steps should be as we get into the case.
So we kind of answered the first and second questions already, but I kind of want to emphasize one point, which I think we've all alluded to, but there's inherent conflict between what the officer needs / wants and the way the incarceral system is set up for these patients and how they access healthcare, and then what the patient potentially needs. And so you need to be able to be the patient's advocate first and foremost. So get them uncuffed, care for them. Their medical care is a priority. That is why they are seeing you. And if the patient can't advocate for themselves, which clearly is sort of set up in this case, then you need to do that for them. Officer goes outside, excuse me, I need to have a private conversation, please step outside, uncuff the patient. As long as the patient is cooperative and not a threat to you, then treat them like you would anyone else, right? And I think the other point to kind of keep in mind is that you just by having law enforcement present in the ED, even if it's not related to a patient who's in custody or incarcerated, already has detrimental effects on patient care, right? There's a potential assumption that all the clinicians are sort of in cahoots with law enforcement. It's really hard to tell the difference, even if they're coming in as a trauma patient, who's who sometimes. And so it's very important to establish, you are the doctor, I am here for you, I am here for your needs, your physical, mental health needs, and I'm not here to work with them necessarily. So I think it's important to establish that separation so it's clear you can build on trust and sort of get a more honest, transparent history, which they may not feel comfortable saying in front of an officer or anyone else that might be in earshot. So I think really establishing that trust up front it's hard, but worth it in the end. I think it's something where you also have to recognize there's sort of this implicit pressure to comply with the officers, thinking that their healthcare is tied to the ability of them providing access, right? Like it's very backwards. In no other way would you ever have somebody who has a power dynamic over you to ask for healthcare from that person, right? So it's a very awkward system for them to function in. And so I think that you always need to make sure not only are you advocating for the patient, but everyone involved in that patient is on the same page with the patient's privacy, of being in earshot, of respecting the patient's autonomy. And so the techs, the nurses, the clerks all need to be on the same page. So oftentimes I will have conversations with them like, hey, these patients' diagnoses, their injuries, they're private. So we need to all be very careful of like what's being said in earshot and all those types of things so that everyone's on the same page. So I think that we don't, as physicians, get enough training, then by no means is anyone else going to have the same understanding as well. And I think the other thing is that in particular this case, I think what's sort of being alluded to is perhaps that this patient is somehow being sort of physically assaulted by the officers, right? They're kind of looking down, they're sort of having a lot of injuries that look concerning, and so it might differ where you work, but you have to find a way to escalate it, right? Like in some sense, we are still mandatory reporters. We still need to report it, even if the person in custody, the arrestee, isn't interested in talking about it. In the same way it is for like DV patients, domestic violence patients, we need to advocate for them, and we still need to find a way to report it. So depending on your system, you can try to talk to the sergeant, whoever of that legal jurisdiction is, the watch commander, to let them know, like, hey, I'm really concerned that there's maybe some excessive force going on. These are the injuries that would make it consistent with a potential issue with the officer. I really want to report it and like have you look into it. And honestly, what happens after that is a little bit out of your hands, but you've tried, and you've advocated for the patient, you've documented that chart, so that at least the patient has some protection. And I think it is tough because a lot of times they don't want to talk about it, but it is something that we need to be mindful of and kind of escalate if we can. So, yeah.
I'm Taylor. I'm a PGY2 resident at Beth Israel. I just want to chime in from a resident perspective, too. This can also be incredibly challenging in terms of the power dynamics. Like, you're still trying to establish yourself as the physician, and then to go in the room and kind of feel, in some cases, like you have to stand up to law enforcement and ask for things that are basic patient rights. So I found that challenging, especially as a young female physician, and most of the correctional officers are older males. But then keep it just in the back of mind, like I'm advocating for basic patient rights. Also, sometimes I'll fall back on something similar to what I would do in a suspected, domestic violence or child abuse case. Just be asking, this is our hospital policy to have people step out for this portion, and then also having in your back pocket, knowing that most of the time officers just need line of sight and that cuffs can be removed.
About the removing cuffs, I recently had a case of a patient who came in custody and needed a decon shower and was cuffed to the bed. And the officers with him they said, no, we can't uncuff him, like hard no. So I had to talk to their supervisors, a number of phone calls, and this was a relatively not critical intervention, but it was enough of a, that 20, 30 minutes waiting for the sergeant or whoever to call me back was a delay in this patient's care. So is there any sort of, and of course I recognize that there's tons of variability in local and institutional guidelines, but like what can we go to or turn to in that moment where the guard has power over me too, because I don't have the key to the cuffs, right? So like what should we do in that sort of instance where they give you a hard no, I'm not going to uncuff them, I'm not going to step out of the room? Is there anything that we can refer to in the moment?
I love that for multiple reasons. So I forgot to introduce myself. I'm Andrea Wu. I'm also from LA. I am the Vice Chair of Clinical Operations and deal a lot of issues that happen behind the scenes. And so I would say escalate to your medical director, whoever your version of that is at your site, to help escalate that with you. I would potentially, if it's a hard, like if they're interfering with medical care, then we need to advocate for that patient. So either the medical director, risk management, somebody needs to like get behind you to have that discussion with the officers. And I think you did exactly the right thing where you escalated to their person as well. But I think this is also where it's really important to have hospital policy behind you. And I think very few sites do, because this is a very uncomfortable space. And it takes, honestly, approaching your local law enforcement as well to work with them on like something that is workable for both sides. But really, I think the one thing that does help is building those bridges before the patient gets to you is crucial, right? How is this information going to pass? Is it going to go through an EHR? Is it going to go through a sealed envelope? You know, I think there are a lot of connections that can be made ahead of time that prevent these scenarios. And so in the moment, I would say escalate on both sides, but I think in a system, we need to have those conversations ahead of time.
I think the only other thing I would add is sometimes the impression we're giving so far might be that we're going to override the officers at all. You know, like it's an antagonistic always environment. And I think the more you can do to diffuse that is also going to help your long-term interactions with the carceral system. And I guess, yes, we're absolutely advocates for patients at the bottom line, but whatever you can do to be creative in that situation while respecting whatever it is that the officers are giving you the hard no on. Maybe they do have information that we don't know about whatever risk this patient poses. You know, would it be possible to cuff them, you know, to themselves so that they are not as much of an escape risk or whatever, so that you can still do your decon. But I think approaching that with a mindset of, you know, open-mindedness and problem solving may get you what you need in the 20-minute time frame.
Absolutely. Whereas
the things that were previously discussed are going to get you what you need overall for your system.
Yeah, no, that's a great point. I do think that we're coming into it, like we're experts in what we do and they're experts in what they do, and we don't know each other's worlds. So I think if you can ask why, if you can try these sort of like reasonable in the moment approaches and try to work with them, then absolutely. But the rest of the stuff, I think, in a long-term improvement of relationships is going to be very key.
Yeah, I cannot overemphasize what you've already said about policies and having them in advance. And this may be used as a driver. The case that you had, you can use as a driver to start negotiating some of those policies. I mean, so we regularly review this, and so when we have an issue about potential abuse, it goes directly to our chief. We have a police department within our hospital. It goes directly to our chief, so it's like a chief-to-chief conversation, but it's a known pathway. There's no ifs, ands, or buts about it. That's how it's taken care of. And that happened because of a case where we weren't sure what to do, and so we sat down and we said, we got to have this, we got to iron this out. So you have a perfect opportunity now to start working on some policies.
All right, thank you so much for discussing this case, and thank you for your question. I think one of the, I'll just editorialize for a moment, but I think one of the things I learned while we were preparing for this is that I don't really know anything. And short of calling legal anytime something happens, which is not the fastest or quickest way to get an answer, it is amazing how much of a lack of transparency or for lack of readily available information or hospital policies. Sandy, sounds like you guys have a system in place, but it seems like it took work to get there. And so I'm does anyone out there do you have familiarity with your hospital's policies, or you do?
So I'm from Taylor, and we're the primary referral center for Harrison County, and there have been, we literally had a patient with a pneumothorax that was handcuffed behind his back, and they were destatting, and they were well, the officer is still dragging in.
Oh God.
And we're well, that's just not acceptable. And so I think to echo what people said of in the moment we just found a different officer, and we're you just need to cut these off or take them off. But then working with legal, I think has actually been the most effective, because they're it is literally illegal to not let them contact the administrative decision makers. It is literally And I think for us, like having nursing know very clearly what the policies are, of like you can't tell the officer the results, make sure charge knows where to access the policy and like physically show the officer like you have to pump them out. I think has just been helpful for building more like the culture of knowing more firmly what the patient's rights are and not, letting shenanigans happen.
Excellent.
I think that's a good point because I feel like our nursing colleagues and other support staff who are at the bedside and spending more time with these patients, they're more susceptible to being intimidated by officers, sharing information, trying to expedite the care plan in sometimes unsafe and unnecessary ways. So it's just important to educate ourselves and to empower not only physicians but everyone involved in the patient's care plan.
And I think, I was just going to say, like, the number of times that I think, I've been in a patient's room and the officer sort of offhandedly has asked, hey, what's going on? What's he waiting for? And you just find yourself, you just answer, and you don't have to answer. I mean, there are certain circumstances, as we discussed, where you have to answer. But for most, you really don't.
So at some point in my career, I couldn't tell you who it was from, and maybe this is a wives' tale. But at one point I was told that there's also some concerns and conflicts around telling the patient specifically next steps in terms of like, oh, we're going to discharge you in an hour, or is any of that grounded in truth or legality? I guess the fear is around like them planning an escape, knowing like if I'm about to be transported to CT, this is my window, stuff like that.
I will add that this question also came up when I was sharing with colleagues that I was preparing this talk, and there was an incident at our hospital that was escalated to legal because a PACU nurse shared with a patient a date of one of their follow-up exams or appointments. So this is out there as well.
Yeah, and it's generally agreed that you don't want to give them specific information, but that's why you need to have the access to the prison medical director, because they're the ones who need to know this, right? And if it's in written documentation or something in the patient's medical record, should they be released, because as we all know that some of these folks get released really quickly, that they will have that information. It will be something that can be given to them. But otherwise, it should be the prison medical director who knows when those appointments are. You should not tell the patient. And the other thing is you should not feel pressured. If you have a patient who's brought in by the police, and the police say, well, they're not under arrest, but please tell us when they're being discharged. Don't do that. That is absolutely not required by law. And I mean, we have that hardcore in our policy that is not our job to inform the officers when they're going to be released, because if they're going to arrest them, they just don't want the jail to have to pay for the medical costs. So do not feel pressured to do that. You are not required by any law to inform officers when someone's being released.
All right, thank you, everyone. In the interest of time, we'll just move on to our next case, and then if we have time at the end, we can keep the conversation going as well. So briefly, this case is a 46-year-old woman with a history of bipolar disorder who's brought in from federal prison with nausea, vomiting, and altered mental status. The corrections officers sort of indicate that a neighboring cellmate had noticed that the patient was talking about sort of leaving it all behind. So when she comes to the ED, she gets intubated for airway protection. She's bradycardic. She has an elevated lithium level and creatinine as well. So nephrology is consulted, and they think that ideally the patient should have a temporary HD catheter put in the next 24 hours so that she can get dialysis. But your nephrology colleagues say, we're not going to proceed with that or put in the catheter without the patient's consent, and the patient is intubated. And so how would we proceed in that case?
So the first question we have is who should clinicians contact for consent? And I just, obviously it doesn't apply in this case, but I think it bears stating the first person is the patient always, because I think sometimes we forget that this is a patient and they are their decision makers. Just because they're incarcerated does not change that. But obviously, when that is impossible, patients always do have some sort of legal POA or surrogate. The question is, how do you determine who that is? So all prisons are required to have that on record. It's a little harder, I think, sometimes in the jail situations, just because the process hasn't always occurred yet of figuring that out. So I think it's actually harder if it's a jail patient usually. But my go-to is to contact the nurse or if you can get in touch with the medical director, great. But whoever's at the healthcare facility in the jail or prison, if you can get in touch with a human being in that facility, usually that's your best point of contact. There is this concept kind of similar to what we were talking about, not giving out information about what future plans are. There's also concern that if we contact a surrogate decision maker, there's some risk, legitimate security risk to the emergency department setting of somebody's family member trying to come and spring them from the emergency department. I think that can be something to consider, but if there's a serious health situation, an incapacitated patient absolutely has the right to having their surrogate decision maker make that decision for them. And that's our obligation to find that person and do our best to comply with those wishes. And I think when it comes to those serious medical decision-making situations, you have to weigh that against potentially a very small security risk in reality to the emergency department. So while I probably would not contact a surrogate decision maker for most patients that come through the ED, primarily because they're their own decision makers, right? Like the number of times you're in a surrogacy situation is usually more likely to be when the patient is quite ill as well. I guess the biggest thing is, and we've alluded to this, but do not use the officer who's presenting with the patient as the surrogate. They generally know very little about the patient. Often they are not even like spending that much time at the prison. They're just there in the healthcare situation supervising. And their primary concern is how long they're going to be there and when they're getting paid and will it shift into their overtime hours and stuff like that. They don't have any sort of vested interest in the well-being of this patient. There are some cases also where really bad things have happened when we defer to those individuals' decision-making, such as making patients DNR who were not, et cetera. So yeah, just basically that is, just because they're there and they're in a uniform does not mean they have any legal rights in representing that patient's decision-making. Next, we have what should clinicians do if they cannot identify a power of attorney or surrogate? And basically, we in emergency medicine do this frequently. We act in the best interest of the patient. We continue to seek a surrogate or initiate the legal process of finding a court-appointed surrogate, if nothing else. Now, hopefully, in the era of boarding, that actually could happen where you need to start initiating court whatever, but hopefully that isn't something that's happening super often in the ED. But yeah, we do this if we can't identify all the time for all our patients, and you should do the same thing with an incarcerated patient. And I think this case brings up the context also of a consultant who's maybe less familiar with that role. And sometimes I think people put on the brakes when they're scared or uncomfortable or out of their zone of, normal operation. And so, having a conversation with that consultant, being like, it's gonna be okay. This is what you do. You treat the patient, you do your best, you do everything you can do. And then this is where you go. This is how you're going to access that ultimate court, appointed, if nothing else, process. And just reassure them that they can do this. They know their medicine. They know how to proceed. And these are the supports to deal specifically with this patient. Next, how would your decision-making change if the patient had capacity and refused care? Again, treat this patient like any other patient in that situation. If they meet hold criteria, you can treat them, according to those criteria. If they don't, you can't. The exception to that would be if you have a court order. Obviously, then you can choose to override their wishes. And then lastly, what is the role of implied consent? I think we've covered that a bit, but we're using reasonable person standard, best interest standard routinely in the emergency department, and that also applies to incarcerated patients. So basically, you want to err on the side of treatment. And I guess I just wanted to also put out a summary idea. There's often a concern that some of our patients may be using medical care to evade incarceration. And I think that the issues that come into play here are that everyone, including incarcerated people, have a right to standard health care, but health care by definition is individualized. And those two come against one another, especially because even standard care in a prison environment or a jail environment can be difficult and non-standard for the rest of the world. You know, things like splints or needles or whatever are just not okay in that environment. So we have to be creative and adapt. But ultimately, just remember that you're the patient's advocate, and I think that gets you a long way. Yeah.
On the second to last question, so we had a patient who basically was on hunger strike, but had capacity, knew what he was doing, would refuse care, and we'd be like, great, we're not going to force feed him, discharge back to jail. Then depending on who was the clinician or provider at the jail clinic, then in a day later they'd be like, oh, he's not eating, send him back. So this man literally came back and forth 7 times. Well, I don't know what happened, but no one really had ideas on our care team or in our department on what to do. At one point we had even called and explained to the on-shift provider, this is why we're not going to do anything. But then they just kept sending him back.
Yeah. And in that case, I mean, you need a court order in order to do treatment, and that would be the communication back to the jail, is that we cannot, unless you obtain a court order stating that, we have to treat this patient, we can't. So, you can send him back, but we'll send him back to you because he has capacity to make this decision.
And I would say even in the cases of court orders, we always have the opportunity to refuse. There might be consequences. I think ACEP actually has specific policy around this where they recommend doing what's right by the patient, and they support you in that. So definitely, look for a court order, but then that's not, you still have the opportunity to kind of not move forward if you don't feel like it's the right thing to do.
And just maybe we can advance the slide because there's a really nice chart that we have that kind of walks through the decision tree involved with this as we ask some more questions. Not to interrupt the question process, but just in case that helps.
Can I just clarify something that I think you said, which was that all patients in prisons have a healthcare proxy identified during their intake? Is that accurate?
I'm going to let you answer that
Yeah.
if you know exactly.
So yes, as part of their,
I didn't know that was part of the process.
as part of their intake, they are asked that question. Now, whether they provide one or I can't be sure, but that's a required part of prison intake.
And is the prison responsible for reporting that information to us if we call and ask? They have that obligation?
Yes, if you call and ask for that, they need to provide it.
Right.
They may also have a emergency contact that they report, which is not necessarily the same person as the healthcare power of attorney or surrogate. So it would be important to distinguish that because I could imagine the name that you get by someone who's not super sophisticated with healthcare could be the emergency contact who may not be the actual person they want making medical decisions.
Sandy, for your system, is that access to that healthcare facility person at the jail or prison accessible 24/7, out of curiosity?
So we can actually call our jail physicians anytime. We can actually page them, but we can also use Epic and send them smart chats and secure chat, messages so they see them first thing in the morning. But there is actually a physician on call for the jail system at all times. And again, that only applies to our county because that's That's the population we're responsible for. And that happened because we had so many deaths at the county prison that we were actually asked to take over the medical care there, and we, you know, it's now staffed by Metro Health nurses. It's the docs are under Metro Health, and so we know exactly what they have. One of the docs, who's the co-director, actually just finished his addiction medicine boards, and he set up an MAT program actually in the prison, which I'm like astounded at. But that's like it's so cool. But I had no idea, you know. I'm like, I feel so lucky.
I think we had one more question.
Specifically in the care of patients who come in custody with psychiatric complaints, so either acute suicidal ideation or non-lethal attempt or something that otherwise we would, you know, have get like an involuntary commitment if they were not in the penal system. What would be what is your management for these? So we've had issue where our psychiatry team will say, you know, I can't IVC them, so I can't do it. You can just transfer them back to jail and have them evaluated. And there's some concern around the risk of transport.
I think that's also hospital dependent as well.
Yeah.
So for instance, at Grady, we see patients from a number of jails or prisons. So I know that when I'm on my float shift, I have a psych patient that's in custody. The first question I ask is to where are they being sent or from where did they come? Because some of those facilities will have a psychiatrist, so that my job as the ED physician is just to medically clear them. And if I'm able to do that, then I know that I can send them back to their particular facility that does have psychiatry that can evaluate whatever acute exacerbations of their mental diagnosis is. However, for us, for facilities that don't have psychiatry, then our psychiatrists are obligated to come and evaluate them after I've done medical clearance. So I think it's really important to get an idea as to what type of resources are available at each of the facilities that you're most likely to see your patients, and to also kind of have some sort of agreement or discussion with your psychiatry team to see what their obligations and or resources are as well. So the main thing for us is just figuring out which psychiatry team is available or what type of resources that they have, and if not, then we treat them just like we would any other patient who's having some sort of acute exacerbation, as to medically clear them, see, you know, whether or not they're a danger to themselves or to the prison. And of course, we kind of just alluded to this earlier, that what that may mean for someone living in the free world versus someone that's in a prison can vary somewhat, but each prison or jail will have different psychiatric resources, and it's important that we kind of educate ourselves as to what that is, so we know that what our obligations to that patient are.
So if they don't have psychiatry at that facility, then you all can commit them to inpatient psychiatry while still in custody within your system?
Right, if that's a recommendation of our, exactly, if that's a recommendation of our psychiatrist and they're going to a facility that can't treat them, then we're obligated to provide them with the care and resources that we would to someone who was not in custody.
I would almost kind of look at it like a nursing home. Like, figure out what that nursing home is able to do, or the assisted living facility, and think of it that way, and not so much that they're in the carceral system, because I think then it changes a little bit your mindset of how you approach it. Like, if that patient needs psychiatric care and they can't get it at the place they're going, then we are still obligated. So it's not the perfect analogy, but I think it helps a little bit in terms of framing what you're arranging for them.
I guess the confusion, and I don't know if my question's clear, it's we all agree that they need care, it's that the
Where?
I can't tell, like they do have like mental health within the facility.
Right.
You can see them, but like ours are saying that there are not, the facilities that I send patients who are not in custody will not accept patients who are in custody. Does that make sense?
Yeah,
Okay.
it does make
This
sense.
is my unit.
Yeah.
That's
I think it's really dependent on where you're working, but I see your point that like they can't take somebody who's incarcerated at this particular normally place you would send your psychiatric patients. Like that I get, but there needs to be some other option available to that patient. So I could foresee this person boarding in the ED, waiting for that like magical place to happen.
Or being admitted medically.
Yeah,
and just
exactly.
Being consulted on by psych
Exactly.
definitely is also an issue I've seen in other
Like
facilities
COVID
as
patients
well.
that also have psychiatric needs, like we have the same problem. They board in the ED until they're like cleared medically for their isolation period for however many days it is in your space that they're still using. Like for us, it's 10 days, so it's awful.
Oh my gosh.
But there's a version of that I think that exists sort of in this situation as well, that you just have to figure out what resources you have in your area.
But I think that conversation with the nursing facility, if nothing else, or nursing experts, professionals at the whatever facility is key, because sometimes you'll get a realistic view of what they can and can't do, even if said thing exists in whatever facility. Sometimes having a conversation gives you an idea of if it really exists and it's really going to work, or if it isn't, depending on the specific needs of your patient. I think
I'm really sorry, but
we're
we're
done.
like 10:55, and I think our next group is here, so we'll have to wrap up. But thank you for the fantastic conversation.
And please come up and join us and continue the conversation.
Out back.
Yes.
Thank you, everyone.
Those people
Thank you,
are looking
everybody.
at us like.